So as we know, the topic for the discussion is alcoholic hepatitis. So when we start with alcoholic hepatitis, the first thing we need to understand is the spectrum of alcoholic liver disease. So normally when somebody abuses alcohol, and there is a spectrum behind it that need to have more than 150 grams per day for nearly 5 to 10 years, about 90 to 95% develop steatosis, about 20 to 40% will develop fibrosis, eventually 20% develop cirrhosis, and then hepatocellular carcinoma. Alcoholic hepatitis falls in the range of fibrosis and then eventually cirrhosis. And then there are the risk factors, which includes females, obesity, dietary patterns, drinking patterns, especially binge drinking, smoking, also comorbid viral hepatitis, hemochromatosis, as well as HIV. So what is very important to understand is that alcoholic liver disease actually has a spectrum, and the patient lies in one of these spectrums, and hence the prognosis also differs in all these spectrums. So the main features of alcoholic hepatitis is, of course, jaundice, and then decompensation. When we talk of decompensation, it is normally ascites in these patients. They can present with also hepatic encephalopathy, but the main symptom that they present normally is with progressive jaundice, and of course a history of recent alcohol intake. Now, it is frequently normally seen in young patients. Most of the trials that have been done all over the world have seen that the trend normally is that the patients are slightly younger in age, mostly in the fourth or fifth decade of their life. So when you need to diagnose somebody with alcoholic hepatitis, you use what you can call the laboratory parameters, which includes an AST, ALT, or an SGOT, SGPT of less than 400, an elevated gamma glutamine transferase, an INR, and a bilirubin of more than 5. Now, this also need to be understood that this is an extremely critical condition which has a high mortality rate, close to 30 to 50% at the end of 3 months. Hence, A, importance in recognizing the disease, and 2, in the treatment aspect of these disease. And most importantly, very few effective therapies are presently medically for alcoholic hepatitis. Hence, prevention of alcoholic hepatitis with very good alcohol de-addiction counseling is extremely important when we are dealing with alcoholic hepatitis. Now, when you're actually, this was an article from Gastroenterology 2016, where they have now divided alcoholic hepatitis into probable alcoholic hepatitis, definitive alcoholic hepatitis, and possible alcoholic hepatitis. When we talk of probable alcoholic hepatitis, and especially in centers where liver biopsy is not readily available, you normally have a patient who has a history of alcohol intake, has an atypical laboratory, like just I had mentioned, AST, ALT range of 400, bilirubin, which is elevated. These are the patients that you probably would label as probable alcoholic hepatitis. If, of course, you do a liver biopsy, and I'll be discussing later the role of liver biopsy, you would find that if the features are suggestive of alcoholic hepatitis, it becomes a definitive alcoholic hepatitis. Possible alcoholic hepatitis is if most of these features are there, but there are also some other confounding factors. For example, if a patient has concomitant hepatitis B or hepatitis C, if the patient has also drug-induced liver injury, then the patient possibly has a possible alcoholic hepatitis. The reason why these definitions are important is because these definitions, if it's a probable alcoholic hepatitis, sometimes there can be an incorrect clinical diagnosis in up to 20% of the individuals. So even though clinical diagnosis has a lot of relevance in alcoholic hepatitis, the need for identification between possible and probable is extremely important when we are dealing with alcoholic hepatitis. Now, coming to the role of liver biopsy, which I suggested is a role for definitive alcoholic hepatitis. A, for example, it reduces the confounding factors, which I had just mentioned earlier. It also assesses the severity of liver disease and cirrhosis, which I'll discuss later, has an implication which has been studied in the other papers. It also tells us about the short-term prognosis, certain factors. Misdiagnosis is unwarranted. And also, when you're doing a liver biopsy in such patients, especially at our center, we also look at the hepatic venous pressure gradient, also called as HVPG. HVPG, once measured in a case of alcoholic hepatitis, has a lot of role in deciding the future course of treatment, even sending certain patients for liver transplant, and also the risk of variceal bleed in these group of patients. So these are some of the common liver biopsy findings that you're seeing, which includes steatosis in the spectrum, which I had mentioned, hepatocyte ballooning, Mallory dengue bodies, inflammatory infiltration with the polymorph nucleosides, as well as the degree of fibrosis. Now, the reason why we need to understand, and that if you can see the slide, the degree of fibrosis, which is labeled in blue, it is a Mason trichome stain. It is that you can now assess the prognosis of fibrosis, and there are multiple articles which tells us which are the factors which are actually beneficial for patients with alcoholic hepatitis and which are the adverse events in a case of alcoholic hepatitis. Now, this is assessed by a score which is known as the AHH score for the prognostic stratification for alcoholic hepatitis. As you can see, there is a stage of fibrosis, there is bilirubin PMN, as well as megamitochondria. Now, most of these factors, if you look at megamitochondria, is in fact shown to have a favorable prognosis in patients with alcoholic hepatitis, whereas bilirubin will be between 0 to 3. If it's indeed indeterminate, it will be between 4 to 5. And severe would be 6 to 9. Again, very important in assessing the prognosis of patients with alcoholic hepatitis. Now, some of the clinical models which are very actively used in clinical practice is the Madry's. And as we all know, Madry's discriminant function of more than 32 implies that a patient actually requires a medical therapy. You also have the older parameters like the MELD or the MELD score, which has a significance in these group. And in fact, there is a study which is now shown that MELD more than 35 actually indicates a and lastly is the Lille score. Now, the Lille score is a score in alcoholic hepatitis which actually tells us the risk therapy. Now, when you actually give these patients steroids, a Lille score is measured, which is at day 0 and at day 7. And if a Lille score is less than 0.45, so this is actually tells us more about the steroid response, and it's very important and very clinically used score, which is used in routine clinical practice. Again, that people have now started combining the scores. There are certain suggestions that if you combine the MELD score as well as the Lille score, you get a better sense of mortality, which is either at 2 months and at 6 months, which can be close to 80 to 95% if both these scores are combined. Important aspect, which is the treatment. And I think the most important thing that you need to know in treatment is first is the assessment of the patient. So first is to make a clinical diagnosis. You've made a diagnosis of alcoholic hepatitis. Now you go for the treatment. You need to assess the severity. You need to assess the number of organs which have been involved, except the liver, for assessing how the patient has to be managed henceforth. Now, treatment of withdrawal syndrome, of course, if the patient has with benzodiazepines and chlordiazepoxide, depending on the category of the patient, if the patient has multi-organ failure and has many systems involved, you possibly will treat withdrawal only after once you have achieved success in treating the organ failures. Insurance of nutrition, and this will be later on in slides, has been shown to be very beneficial in patients with alcoholic hepatitis, especially with a high-calorie diet. It has been shown that alcoholic hepatitis actually responds to nutrition. So nutrition has to be counseled, nutrition has to be maintained, and is still one of the most effective treatments for alcoholic hepatitis. Very importantly, infection screening has to be done, because infection screening has been shown that in alcoholic hepatitis, there's a higher tendency for increased infections. And as you would see later, that steroids are used for some of the cases for alcoholic hepatitis. And it is very important that you rule out infections before you start treatment with steroids. Now, coming to nutrition. Now, nutrition, as you've seen, that this was an article which showed that patients with alcoholic hepatitis normally have a poor calorie intake. And if the patients have a poor calorie intake, there's a higher chances of mortality in these subgroup of patients. And as you can see in the graph, mortality, calorie intake of 1,000 kilocalories or 1,500 kilocalories or less than 1,000 calories actually portended a higher risk of mortality in these group of patients. So better the calorie, better the liver is how we need to remember this. So higher nutrition is very important. This was a paper in Gastroenterology in 2016, where they had randomized patients with severe alcoholic hepatitis and seen them over for 14 days. And what they realized was that patients who had a higher calorie intake, even though this study did not show significant difference, they did show that there was a reduction in mortality in the group of patients who were fed well. Eventually, there were few meta-analyses which have been done, and some of them have shown a decrease in mortality of close to 20%. The problem that comes with alcoholic hepatitis is how to feed the patient, because the tolerability of feed in such patients are difficult. Sometimes you can use a nasogastric tube or a nasojejunal tube to feed these patients if there is a poor oral intake with these group of patients. This is the consensus report on the nutrition support for alcoholic liver disease. As you can see, the calorie intake is extremely high. It should mainly comprise of carbohydrates and calories. And on the side, you can see a 500 kilocalorie evening snack, which is on top of what you're actually giving. So you probably give a 2,500 kilocalorie diet along with a 500 kilocalorie evening snack is what is actually recommended. Very importantly, all the micronutrients, along with the macronutrients, we normally tend to forget the micronutrients, which include zinc, selenium, folic acid, which these patients, especially thiamine, which these patients are normally deficient in, which also has to be taken into account when we are planning a diet chart for these patients for the alcoholic hepatitis. Now, the other specific treatments or the medical treatment for alcoholic hepatitis in clinical practice includes pentoxyfylline, prednisolone, NAC, which is N-acetylcysteine, anti-TNF, GCSF. You have liver assist devices, FMT, and liver transplant. Most of these therapies that have been done still do not show a very long-term survival benefit. And now with recent data emerging, I think early liver transplant in alcoholic hepatitis is also finding a role in these patients with alcoholic hepatitis. So when you look at pentoxyfylline is a very old drug. In the year of 2000, gastroenterology, they had shown that pentoxyfylline, when given versus a placebo, had an effect with reducing the 6-month mortality. It also had a reduction in the hepatorenal syndrome. So it was suggested that if a patient had a kidney disease along with alcoholic hepatitis, you could give these patients pentoxyfylline, and that would help. However, when this they had shown that there was no reduction in the 28-day mortality. They're limiting its usage today in clinical practice. People also looked at combining pentoxyfylline with steroids. And also there was no combined benefit when you actually combined steroids as well as pentoxyfylline. The other infection of alcoholic hepatitis, but with all the data which is very limited in today's practice. Coming to the most important, and steroids are this is a journal. This was a landmark paper in Gut in 2011, and then subsequent hepatitis improves the 28-day survival in patients with alcoholic hepatitis. Steroids, as I had shown you about the Lille score, responded to the Lille score, had a decrease of less than 0.45, had a better chance of survival and a reduction of mortality. However, what we need to understand with steroids is that steroids, they were not able to show a long-term mortality. So 90-day mortality was not significant in is now limited in patients who are not infected, who are prime candidates for the reason for steroids. As you can see the slides, steroid ineligible patients are nearly 70%. So you normally have only 30% who actually meet the criteria for receiving steroids. And once even they receive steroids, about 10 to 15 respond to steroids, where we use the Lille score to decide. And that is why the role of liver transplant or early liver transplant is also now emerging in patients with alcoholic hepatitis. We must also understand there are some other therapies like fecal microbiota transplant, which we will discuss later, which has some implications for alcoholic hepatitis. So this was the same slide which I had shown you, which had shown that there was no increase in 28-day survival. So when they looked at 90-day survival in steroids, they did not find anything which was significant. So the most of the important factors include increased susceptibility of infection and recidivism. Recidivism means that they start consuming alcohol once they have responded with steroids. So because of the fact that infections are a major source or a risk factor in patients with alcoholic hepatitis, steroids sometimes cannot be given in these group of patients. So infections in severe alcoholic hepatitis, well, we need to understand before even we start therapy, we must remember that baseline infections are seen in nearly 12 to 26% of the individuals. It has been seen that baseline infection do not impact the 90-day mortality, but it also has to be noted that once on treatment, a patient develops infection, that is where the mortality is very high. So hence, once you have screened a patient and the patient does not have infection, if he does subsequently develop infection while he's on steroid, that in fact increases the risk of mortality. Hence, that is why steroids are still very difficult to be given in these group of patients. Early day 7 infection is normally seen in non-responders. You see normally peak infections anywhere between the 2nd to the 3rd week. And most of these infections are actually multi-drug resistant infections. and also fungal infections. In clinical practice, fungal infections are extremely common in patients receiving steroids, and a high index of suspicion when you're treating somebody with steroids and alcoholic hepatitis has to be kept for these infections. Prophylactic antibiotics has been studied for infections. Some of the studies have not shown a prophylactic role, but in general, yes, prophylactic antibiotics can be considered in certain high-risk individuals while you're deciding for steroids. Now, aspect, and which is the bacterial infection versus sterile inflammation in alcoholic hepatitis. And these are some of the reasons how they started looking at the gut reasons why. And this is the basic sterile inflammation, where there is a damp inflammatory cytokine and a sterile inflammatory response, versus a when somebody has bacterial infections. And most of these patients have something called as compensatory anti-inflammatory response syndrome, which also is one of the factors which leads to more death in these group of patients, because there is an immune suppression response. All of these factors in these group of patients. So inflammation is extremely important in cases of alcoholic hepatitis. When we talk of immune paralysis, all cirrhotic patients, or even most of the patients, have immune paralysis. And that is the reason why most of these infections, some of the basic factors include a neutrophilic phagocytic defect that you see in patients with acute and chronic liver failure, the monocyte expressions, the decreased, as well as the increased intrahepatic interferon gamma are some of the reasons why these patients have immune paralysis. So patients with alcoholic hepatitis, patients with cirrhosis are at paralysis, where there is an increased risk of sepsis in these group of individuals. So like I had said earlier, steroids are something which need to be given only when you need to have a proper patient selection. There should be a infection. Early cessations, we need to know when you need to stop a steroid, if at all it has been started, and proper nutrition are some of the basic aspects of starting steroidal therapy. So when you look at a patient selection, some of the bedside tests that can actually be done in any center is a baseline NLR ratio. And the NLR ratio has been shown in a very recent study that higher the NLR ratio, higher the risk of acute kidney injury or infection in alcoholic hepatitis. And it has also shown that if there is a decrease in NLR, those are the patients that may benefit from steroid therapy. So this is a very simple NLR ratio that can be done at bedside to determine if a patient can be given steroids as well as prophylactic antibiotic when you're considering therapy. The other would be the other therapeutic options. And as you've seen here, that patients with steroid have more infections at day 7. And patients who have received prednisolone plus antibiotics, there was, even if you gave antibiotics to them, there wasn't much difference. Hence, prophylactic antibiotic in general is avoided. But unless and until there is a high-risk feature in patients with alcoholic hepatitis, prophylactic antibiotics are normally not given. The other is, I had discussed earlier, steatosis on liver biopsy predicts outcomes. I had mentioned earlier that this is one of the high-risk factors for patients who develop worse outcomes with patients with alcoholic hepatitis. So treat infection before corticosteroids is some of the older saying that has to be done. So first you need to treat infection before you go. The other is the early cessation. So if there is no benefit with steroids, or if there is a high risk of infection, you probably need to stop steroids before it leads to infection. Now, this was another trial, which is an NEJM trial, where they had looked at N-acetylcysteine, which is an antioxidant, and they had tried to compare it with prednisolone and had shown that there's a decrease in infection when you give N-acetylcysteine with patients with alcoholic hepatitis, as well as a decrease in kidney injury. So this is something that also can be added to the medical management. And some of the antioxidants that have been used, which includes vitamin E, selenium, zinc, and folic acid, seem to have some role, but I think N-acetylcysteine is the one which seems to have a bigger role. So N-acetylcysteine in combination with steroids has been shown to reduce certain degree of infection. Antibiotics as much as amoxicillin, you have GCSF, you have obeticholic acid, you have fecal microbiota transplant, you have liver devices which have been mental stage. Some of them now have studies, and some of them are possibly promising therapies. So as I discussed earlier, this is an inflammatory state where you have increased risk of infection. You have TNF alpha and interleukin 1. And TNF has actually, that is infliximab. Infliximab is commonly given in patients with IBD. So they used infliximab. What they had seen was that it caused fatal infections in thereby this trial was abandoned, and anti-TNF at present at least does not have a role in alcoholic hepatitis. Was interleukin 1, and interleukin 1 has two common drugs, which is anakinra as well as IL-1. The reason behind it is when you block the IL-1, you also cause an increase in hepatocyte death, you cause steatosis, you activate the stellate cell, as well as you decrease the inflammation, thereby limiting the inflammatory barrier, which is there for IL-1. So other was GCSF, and in fact, from ILBS, it's shown that GCSF, especially in patients who were steroid refractory or had not improved with steroids, the role of GCSF in this group of patients had shown that there was a survival benefit when you use GCSF. The reason how GCSF works is that it basically improves the regenerative capacity. And how it does that, it mobilizes the CD34 positive cells. It also increases the phagocytic functions of the neutrophils, thereby decreasing the infection. This was a study which was done in 2012 from All India Institute, which had shown that GCSF cells and improved survival in patients with ACLF. And if these patients were not treated, so there was an arm which was not treated, 70% die in 2 months. So this was some of the salient features in that. Then this was another study from PGI Chandigarh, where they had used GCSF, where they had compared it with Pentoxyfylline, and there were less infections and liver failure in the group which received GCSF. Now, coming to an important aspect, which is intestinal dysbiosis. So as I've been talking about inflammation, I've been talking about infections. A common thing which is now being seen in cirrhosis in general is the role of intestinal dysbiosis. That is the barrier function which is there in our own body. So when you look at an alcoholic liver disease patient, you see that this patient has hepatocyte damage, he has Kupffer cell activation and hepatic stellate cell activation. Also, when you look at the gut, it causes a decrease in the barrier which is there in the gut, thereby the permeability of the gut is increased. There is more exchange of bacilli. These bacilli then in turn cause an increase in inflammation and thereby increasing the inflammatory markers. Hence, gut has become an important aspect of treatment of alcoholic liver disease. This is an FMT unit by Dr. Apoorv. As you can see here, he's preparing an FMT of a donor, of a screened donor of a patient who was receiving for ACLF alcoholic hepatitis. And here it was done by giving a nasojejunal tube. And this was given for 7 days in these group of patients. And many of these patients actually had an improvement in survival. The paper is still under peer review and should be published very soon. This was the first trial that we did at ILBS from Dr. Phillips. And these were all patients who were steroid ineligible patients. So they could not receive steroids. So first FMT was done versus Pentoxyfylline. It was a pilot randomized study. And it had shown that FMT increased survival, it increased the median survival, as well as decreased the encephalopathy, reduced the new onset AKI, reduced MELD score. And this is where the next concept was made, where we actually directly compared FMT versus steroids in patients with ACLF. We looked at the bacterial profile after FMT. And as we have seen in this is that there's an increase in bacteriocytes as well as decrease in Proteobacter after FMT, which is what is normally required. Normally, higher the Proteobacter, the bad the microbiome profile. And it has also shown that Bifidobacter, there's an increase in abundance, which is a good microbiota at baseline, from baseline at 3 months. Now, liver transplant for alcoholic hepatitis remains one of the key factors. The reason why liver transplant was difficult to be done is that there was a rule that the patient should not have received alcohol for nearly 6 months. There was an abstinence rule of 6 months. Hence, now there is a call to change this rule, and there are now increased studies which have shown that early liver transplant in patients with alcoholic hepatitis also improves survival in these group of patients. Now, the most important aspect when you're dealing with alcoholic hepatitis liver transplant is the risk of recidivism. That post-liver transplant, how many patients will actually relapse to alcoholic therapy? Now, there are many scores which determine that. One of the more recent scores is the SALT score, which actually scores a patient at how much risk the patient is to develop recidivism post liver transplant. And the other aspect of alcoholic hepatitis and liver transplant is the role of infection. So if a patient has infection, sepsis, has more than 2 to 3 organ failure, possibly may not a liver transplant. So the debate always rises between a medical management as well as an urgent transplant, live donor transplant, because in our country, most of them are live donor transplants. So steroids versus FMT versus a live donor transplant. It is a very careful decision which has to be made after seeing the assessment of the liver disease, infections, sepsis, availability of the donor, and how early that a patient can undergo a liver transplant. So these are some of the issues, and also futility in these group of patients. We still need to know that only less than 2% of alcoholic hepatitis still get a liver transplant. So the magnitude of a liver transplant in these group of patients is extremely high. When you look at the advantages of a liver transplant is that, the surgical aspect of it is that, there's a better quality graft, there's shorter cold ischemia time, and optimizing a medical patient. And an ideal patient will also have somebody with very good psychosocial support, with very good family backing. So that is very important when you are actually talking about a liver transplant, or even in a medical management. Psychosocial support for a patient with alcoholic liver disease is extremely important when you're dealing with this group, because we need to prevent recidivism, which is close to more than 70% at 6 months, patients with alcoholic liver disease. Now, these are some of the studies which have been done, and most of these studies have shown that there is very low relapse rate in about 3 to 26%. But again, these are studies which are still evolving. Most of the median survival, as you can see, Mathurin has shown a median survival of close to 2 years post liver transplant. The number of patients transplanted is still very small, and this data is emerging over a period of time. And this is again which shows a liver transplant versus alcoholic cirrhosis. AH is better. And does alcohol relapse influence long-term survival? Like I said, 60 to 70% relapse. And the moment they relapse, the problem is that the alcoholic liver disease may worsen. So hence, the follow-ups in a clinic, disciplinary team, which includes psychosocial support, de-addiction is extremely important, and all the team members have to be trained before we do that. Some of the use drugs that you can give are Baclofen in alcoholic liver disease, but most importantly, a psychosocial support should be there. So I would suggest that we write a prescription for a patient with alcoholic hepatitis, where we actually first make a diagnosis of alcoholic hepatitis. In most scenarios, it will be a clinical diagnosis in the absence of a clinical biopsy. You look at jaundice, you look at the recent intake of alcohol. And after that, once you have detected somebody with alcoholic hepatitis, based on the organ failures and the risk assessment, you either you send him either to a medical therapy or a transplant therapy. When we talk of medical therapy, nutrition is extremely important, with including of an evening snack. Then we look at the discriminant function, which should be more than 32 and MELD more than 20. Once you have a patient with this, you need to screen him for infections. Once infections has been treated, you can start the patient with Prednisolone 40 mg per day. At day 7, you look at the LIL score. If the LIL score is less than 0.45, the patient is given these steroids for 28 days. But if at day 7, the LIL score is more than 0.45, you need to stop this therapy and then possibly refer the patient for transplant or other alternate therapies, even though transplant remains the gold standard in these group of patients. Thank you.